Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
So thank you all for joining us for this conversation in interferon gamma-mediated diseases. During this segment, we're going to discuss some of the updates from the recent American College of Rheumatology conference. I'm Dr. Pui Lee. I'm Assistant Professor of Pediatrics at Boston Children's Hospital, and I'm joined by my colleague, Dr. Alexei Grom, who will introduce himself.
Yes, I'm Alexei Grom. I'm a professor of pediatrics and a translational researcher in the Division of Rheumatology at the Cincinnati Children's Hospital Medical Center.
Excellent. So we will provide you an update from the recent ACR Convergence Conference that took place in Washington, D.C. in November. So learning objectives today should be able to identify and differentiate the clinical presentations of different forms of interferon gamma-driven diseases. In the context of rheumatology, we often talk about macrophage activation syndrome. It's also clearly relevant to hemophagocytic lymphohistiocytosis as well. We're going to develop strategy to incorporate point-of-care testing and also laboratory processes to expedite the diagnosis and treatment of this condition. And we hope to be able to analyze recent advances with the therapeutic context to understand the clinical applications. And finally, we want to integrate the care strategy with all this information to help support treatment for patients with these conditions. So I guess first, let's just start with introduction to the major point of this conversation is thinking about macrophage activation syndrome. And Dr. Grom is very familiar with this, an expert in the field. And in American College of Rheumatology, the Convergence meeting, of course, we discussed a lot of this, what we call secondary HOH or macrophage activation syndrome. And in the pediatric setting, right, we see this most commonly in the context of systemic juvenile idiopathic arthritis. So there are a number of studies that are related to MAS in the patients with systemic JIA. And just to put in context that this is it happens in 10 to 15% of systemic JIA cases across the world, and often in really young children between the age of 1 to 5. So in addition to arthritis, patients with systemic JIA, as most of you know, they also have daily fever, a rash, and a number of systemic inflammatory features. And MAS is one of these features that are they could be very severe, and they could develop very quickly, either at disease onset and also come with various disease flares. So it's very important for us to recognize this condition and start treatment. So fortunately, there's a number of studies now that have shown some of the mechanistic basis, both at the cytokine level and also at the cellular level about the biology of this to allow a better targeting. So Dr. Grom, what do you think about the key mechanism of MAS? I mean, there are a lot of studies done at this point to try and understand this process. Maybe you can quickly summarize for us some of the key points in the field as we think about some of the updates.
Well, certainly it's a very, very perplexing complication of rheumatic diseases in general. By far, it most common in the systemic juvenile idiopathic arthritis. It's viewed as a cytokine storm that is driven mainly by T cells, and if you look at those T cells, they are predominantly CD8 positive, as well as overly activated macrophages, often exhibiting hemophagocytic activity. And the expansion of these cells leads to a massive inflammatory response, typically associated, I would say, with 4 cardinal features: cytopenias, liver dysfunction, coagulopathy consistent with disseminated intravascular coagulation, and extreme hyperferritinemia. And again, it's a cytokine storm, and the interferon gamma is now emerging as one of the key players in this particular cytokine storm, and it seems to be produced predominantly by these CD8 positive T cells that we see in the inflammatory lesions in MAS. Now, briefly, I would like to mention that if you think about the interferons in general, there are type 1 and type 2 interferons. Type 2 interferon gamma is a type 2 interferon. Examples of type 1 interferons include interferon alpha and beta. And there are some differences in the way this cytokine function. Before we get to those differences, briefly, I would like to mention another relevant cytokines in MAS. It's IL-18. We see strikingly high levels of IL-18 in this patient population. And if you remember, IL-18 was described in the late 80s as a interferon-inducing factor. So we know that it has this general ability to stimulate T cells to produce interferon gamma. And based on that, the assumption is that it is a major player in MAS as well, through that enhancing the production of interferon gamma by T cells. So again, coming back to the distinction between type 1 and type 2 interferons, as you can see here, they actually signal through different receptors. There are differences in terms of the signaling molecules they utilize. And if you look at the bottom of this figure, they are also different in terms of the type and number of genes they activate. Those genes are certainly overlap, but some of them are induced almost exclusively by type 1 interferons, and some are induced almost exclusively by interferon gamma. And a good example here would be the chemokine called CXCL9 that is induced almost exclusively by interferon gamma. And we often use it as a measure of interferon gamma tissue activity. Briefly now, we would like to go over some of the more mechanistic studies presented at the ACR that dive deeper in the nature of this T cell activation and interferon gamma production. And Dr. Lee, I think you would discuss this, right?
I'm always fascinated by the cellular profile and how complicated it is in driving this cytokine storm. And particularly in the last few years, where for a long time, we really think of MAS as a process driven by both CD8 T cells and with some interplay with the myeloid cell population. I thought for a long time this is much more of a theory in the field, and there's not a lot of way to prove that. But there are a number of recent studies in the past couple of years, and also at this ACR, that show probably these are really the two important subpopulations. So one is the CD8 T cells, and the other are the myeloid cells, so like the monocytes, for example, macrophages. So this is one of the presentation from Dr. Susan Kennedy from Seattle, looking at single-cell RNA sequencing of cells from patients with systemic JIA with or without MAS. There are a couple previous studies on this area, and this one sort of highlights some additional findings that are novel in the context of the bringing in the interferon that Dr. Grom just talked about. So in this particular study, the authors looked at the different expression profile of the various cell subsets in MAS, and they found the population of CD8 T cells that show lots of cellular activation markers, and as well as interferon gamma production, which is consistent with what we know in terms of this population of T cells that drives the majority of interferon gamma for the cytokine storm. But what they also did is looking at the monocyte population. And in addition to having a signal that looks like inducible by interferon gamma, which is expected in the context of having so much interferon gamma around, they also see that these monocytes have a lot of type 1 interferon signature. So really bring home that idea that Dr. Grom talked about, that maybe this is a combination of type 1 as well as type 2 interferon that drives the cycle of inflammation. They also bring in some potential causes of these production of these cytokines. So toll-like receptors, as we know, are innate sensors to sense different molecular signatures from viruses and bacteria, for example. And it could be the viral sensing from monocytes that starts out this whole loop, right, to make type 1 interferon, which then activates other cells to make interferon gamma for these T cells to generate and perpetuate this cycle of inflammation. So this study at a very broad level, right, bring in information about how different cells interplay in driving this cytokine storm, which I thought was particularly interesting. And extending that idea that these CD8 T cells may be important, right, for the pathogenesis of MAS, this is the poster from Sebastian Vastert's group. And looking at this more in a group of patients with systemic JIA with or without bacterial activation syndrome, to see if there's sort of the skewing of this T cell subset, right, that we think is responsible for the interferon gamma production. And the marker they use here is CD38 and MHC class 2 HLA-DR. So there are a few studies, again, in the past few years to show that this T cell profile, particularly CD8 T cells, seem to be quite specific in both HLH and MAS. This started out with the work by Michael Jordan's group, followed by colleagues in Italy. They identified these cells in both primary HLH as well as secondary HLH or MAS. And And this poster looked at the patients with systemic JIA who have active disease, inactive disease, and those with MAS. And you can actually see in the diagram here that as reproduced from other studies, that the patient with MAS are a very high percentage of the CD8 T cells, and you can see upwards of 60-70% majority of the T cells can actually have this profile. And what they saw also, what's interesting is in active systemic JIA, right, patients that do not fit diagnostic criteria for MAS at the time, so mostly have either fever, arthritis, or skin rash, but without the hallmarks of MAS. They also have an increased percentage of these cells compared to the patient that have inactive disease. And what that tells us is perhaps even when they're not in MAS yet, there's this predisposition, right? Whether it's from high levels of IL-18 or other factors that perhaps would explain why MAS is so much more common in systemic GIA compared to other rheumatologic diagnoses, particularly in children. So I think there's additional studies from the poster actually that show that it is in vitro. They can also generate these cells by culturing T cells with IL-18 and type 1 interferon, which again brings in the message of the maybe not just interferon gamma, but also type 1 interferon as a player in driving the cytokine storm. So what we talked about so far is a lot of what we see in the blood, right? These are peripheral blood markers of T cell populations that drive perhaps systemic inflammation. But as we know, MAS is also also involves a number of different organs, including liver and lungs. So maybe Dr. Grom can tell us a little bit about some of the recent advances and looking at these specific pathological features in these organs.
Yeah, this is an interesting poster from Ezra Elozeli, who is a pediatric rheumatologist who actually just took a new job in Texas. I think it's the very beginning of an interesting project focused on the liver involvement in systemic juvenile idiopathic arthritis in general, and specifically in patients with MAS. I have to say that over the last years, we started seeing more and more patients with, I would say, chronic recurrent smoldering macrophage activation syndrome. And in many of these patients, the MAS activity is limited to the liver. So these patients continue to show elevated liver enzymes and other markers of liver injury. And it may be very difficult to distinguish this patient population from systemic GA patients with other types of liver involvement. And I'm specifically referring to the anakinra-induced liver injury, as well as sort of a conventional liver involvement in the systemic juvenile idiopathic arthritis itself in general. It's very important to distinguish these clinical scenarios. If it's MAS, we need to treat it as macrophage activation syndrome. In fact, anakinra could be one of the medications that we would use here. If it's an anakinra-induced liver injury, the next step would be exactly the opposite. We may need to stop anakinra in that patient population. So the purpose of this project is to long-term develop biomarkers that would distinguish these three clinical scenarios. So as a start, Dr. Elozeli started looking at the histopathological differences in these three different scenarios. And in her initial study, she included several patients with liver injury caused by MAS. In systemic GIA, several patients had anakinra-induced liver injury, and there was also a good group of patients with liver disease caused by the underlying systemic juvenile idiopathic arthritis. And the main conclusion of this study, again, T cell expansion, predominantly CD8 positive T lymphocytes that distinguish the patients with MAS in the liver. And that is shown in the upper panel on the right side. That is staining. This is staining for CD8 cells, and you see that patients with MAS are clearly distinguished by massive expansion of these CD8 cells. And if you move to the bottom of that figure, you see that it's also associated with massive activation of histiocytes in the liver. In this panel, we are looking at the CD163 staining that identifies histiocytes. And again, you see massive expansion. You see that many of them are activated. Many of them exhibit hemophagocytic activity. So these two features, the expansion of CD8 T lymphocytes, as well as activation of histiocytes go together and distinguish patients with MAS in the liver from other types of liver injury in systemic juvenile idiopathic arthritis. At the moment, we still need a biopsy to distinguish these clinical scenarios. Again, the purpose of this project long-term to develop biomarkers. And my understanding that Dr. Alexei Lee is now performing spatial transcriptomic analysis of these samples to perhaps identify potential biomarkers that could be detected in blood and used as a clinical test to distinguish these three clinical scenarios. So I think it's a very beginning of a very interesting and very relevant project. The other issue that we are dealing with right now in our field is the chronic parenchymal lung disease, a seemingly new complication of systemic juvenile idiopathic arthritis that emerged, I would say, in the early 2012, 2013. We see more and more of these patients. And interestingly, if you look at the overall clinical patterns in those patients, in this patient population in general, about 80% of these patients have a history of macrophage activation syndrome, and usually recurrent. So the question is whether recurrent episodes of MAS in patients with systemic JIA have overlapping pathophysiologic mechanisms with this lung disease. So Dr. Schulert and his group, their main goal is actually to explore this phenomenon in the animal model of macrophage activation syndrome. This particular model is utilizing repeated stimulation of toll-like receptors with CpG. These animals typically develop many clinical features of macrophage activation syndrome. And a few years ago, Dr. Schulert published a paper describing the inflammatory activity in the lungs in this patient population. So all the previous studies would typically look at an acute episode of MAS in this model. The purpose of this study was to see what happens if we keep inducing MAS repeatedly, what happens in the lungs, how this recurrent MAS picture, what kind of impact it has on the behavior of the inflammatory cells in the lungs. And the sort of main conclusion of this study is that, so typically, if we look at healthy lungs, we see a very interesting population of alveolar macrophages that perform multiple functions. They certainly have the ability to phagocytose and remove foreign materials that gets into the lungs. They also have the ability to clear pathogens, as well as actually recycling the old surfactant. And in fact, poor ability to recycle surfactant could lead to a very peculiar complication called pulmonary alveolar proteinosis that in fact we see in patients with this parenchymal lung disease. So in the animal model of chronic recurrent MAS, Dr. Schulert observed massive changes in the populations of macrophages in the lungs. The population of these protective alveolar macrophages seems to be decreasing. At the same time, he starts seeing more and more macrophages that clearly have this pro-inflammatory potential, as well as the ability to induce fibrotic changes. And I think it's a very promising model. I think his next step will be to further examine the sort of the behavior of those pro-inflammatory cytokines and compare the behavior of those macrophages to what he's seeing in patients with systemic juvenile idiopathic arthritis and the lung disease, with a goal to perhaps identify new therapeutic targets. But I think one important conclusion from this study is that clearly it's the systemic inflammatory activity of MAS that drives the abnormal behavior of the immune cells in the lungs drives the accumulation of these pro-inflammatory cytokines. Again, it has a direct clinical implication. It clearly suggests if we want to get the lung disease under control, we need to control the systemic inflammation. And I think, again, it's a animal model, but I think it's directly relevant to our clinical practice.
Important point to interject here that this is not only important, but there's also some level of controversy in our field about the origin of the lung disease as well as the management for this condition. There's a great debate session in pediatric rheumatology that should also focus on the lung disease associated with systemic GIA, and of course this is also important for MAS, right? These are also the same profile of patients that have recurrent MAS. These are the same patients that often have the progressive lung disease. And from a timing standpoint, a lot of these, these cases came in the era of the last couple of decades when we started using a lot of these biologics against IL-1, IL-6, and then others. And so there's this controversy about, is it the disease, is it part of the disease itself, or is it induced by the medications that we're now using these days? So I do encourage that you guys watch the great debate for this topic, which is really relevant for interferon gamma-mediated disease in general.
That's another interesting study that I thought was fascinating. So we all know that defective cytolytic function, abnormal cytolytic pathways are responsible for the development of HLH or the cytokine storm in patients with primary HLH. The mechanisms are still not entirely clear, but what typically happens, if you think about the way the cytolytic cell function, they approach their targets, which could be either cells infected with viruses or malignant cells. They form a firm contact with those target cells, and that area of contact is called immune synapse. The next thing that happens, the perforin from the cytolytic cells is released into this immune synapse. When it's there, perforin gets polymerized. It literally forms tubule-like structures that inserts themselves into the target cells. It creates holes in the target cells, and then through those holes, granzymes enter the target cells and kills them eventually. So that's a mechanism of killing. And during that process, the cytolytic cells also release pro-inflammatory cytokines, particularly interferon gamma. So what happens in patients with primary HLH when we have significant defects in that cytolytic pathway? The cytolytic cells still approach the target cell. They form that immune synapse, but the killing takes time. It's not as quick as in healthy people. As a result of the synapse time, as we define it, is prolonged. And since it's prolonged, the cytolytic cells produce more and proper pro-inflammatory cytokines, particularly interferon gamma. So the point is that the synapse time, the time that the acytolytic cells spends in direct contact with the target cells, determine the amount of cytokines that are going to be released during that process. And the longer the killing, the more cytokines are produced. And the overall consensus right now that prolonged synapse time clearly promotes increased production of cytokines, contributing to the development of this cytokine storm. So Dr. Scott Kenna and his group developed an interesting in vitro assay, in fact, to measure the synapse time, the duration of the contact between the cytotoxic T cells and the target cells, as well as the amount of interferon gamma produced during this interaction. And they clearly show that this mechanism is relevant to not only primary but also secondary HLH. And again, I think it's a very basic study, but I think I see clearly that there are clinical scenarios where we could use this assay for clinical purposes. As an example, imagine we have a very young patients with macrophage activation syndrome. When macrophage activation syndrome presents at the very beginning of the disease onset, of systemic juvenile idiopathic arthritis, it may be very difficult to distinguish it from primary HLH, particularly in younger kids. So typically when we deal with this scenario, we treat MAS or HLH, but we also send a sample for genetic testing. Then finally, the diagnosis is established. We know that it's systemic juvenile idiopathic arthritis complicated by MAS, but the genetics comes back and we pick up some variants of uncertain significance in the cytolytic pathway, in the genes involved in the cytolytic pathway. So what do we do with that information? And I think this actually functional assay could be used to assess the functional significance of those variants and then determine whether the presence of those variants increase for future episodes of MAS for those patients. So I think, again, it's a very basic study, but I clearly see that this assay could be clinically relevant, could be introduced in clinical practice.
I think that's a very good point in terms of some of these variants being difficult in terms of figuring out whether these are pathogenic or not pathogenic in the context of HLH. And it's also applicable, before I get to this next study, that think about patient systemic GIA, right? Dr. Grom and others and their groups have identified probably a third of kids with systemic GIA have some variants that have been linked to, and genes have been linked to primary HLH. In a heterozygous manner, of course, not in a biallelic way. So having this type of assay would definitely help us sort out the risk factors that help to promote cytokine storm in this condition. So next, let's maybe give us an update on the efficacy and safety of emapalumab, which is a monoclonal antibody that of course blocks interferon gamma and has been shown to be quite effective in primary HLH, and in a more recent publication in macrophage activation syndrome associated with systemic GIA as well. So this is actually a poster from Dr. Grom and colleagues I think it's a follow-up study, right, to the original clinical trial, where in the publication from Annual Rheumatic Diseases, it was shown, I believe, around 12 patients, right, and were treated with emapalumab with MAS, and have demonstrated safety as well as efficacy. Of course, that's still a small number in the context of clinical trial, and this study provides an extension in terms of the data set to show how well it was tolerated, and also some of the biomarkers. We think about CXCL9 and CXCL10 as direct markers in interferon gamma, where to see those markers improve fairly rapidly after treatment, as well as the ferritin, which is a traditional marker we've been using to follow macrophage activation syndrome. It looks quite promising, even in an expanded cohort. So Dr. Grom, why don't you walk us through this poster?
Yes, very briefly, I would like to mention a couple of things. First of all, this study was essentially the first prospective study of a drug in macrophage activation syndrome. If you look at the pooled analysis, overall 39 patients were enrolled in this study. And all these patients were very difficult. All of them failed high-dose corticosteroids. The vast majority of them received daily intravenous pulses of solimedrol at 30 milligrams per kilo and continued to have worsening MAS. About 80% of the patients enrolled in this study failed anakinra, and then about 70% of these patients failed cyclosporin. So it was a very, very difficult patient population with significant comorbidities. About 70% of the enrolled patients had either chronic lung disease or some kind of a liver involvement. So very difficult patient population. The second point I would like to make about this study is, again, for the first time, the investigators here tried to develop an outcome measure for macrophage activation syndrome. And it was a very high bar, I would say. The outcome measure, the primary endpoint was defined as a complete response. And it was defined as a complete resolution of all the clinical features of macrophage activation syndrome that were present at enrollment, in combination with a complete normalization of 7 laboratory features relevant to macrophage activation syndrome. And it includes cytopenias, liver enzymes, serum fibrinogen, as well as ferritin and LDH. So when this very strict definition of a complete response was applied to this patient population. Only about 58% of the patients met the definition of this response, which was a bit disappointing. But in the analysis of the data, we realized that, in fact, there were many patients who did not meet the definition of a complete response only because of LDH, only because their LDH remained slightly elevated. And as we just discussed earlier, we see more and more patients right now in our clinical practice with systemic JIA complicated by the lung disease or liver disease. And in those patients, the LDH, in fact, never normalizes. So as a result of this evolution of the disease, I would say, the LDH lost its specificity for the diagnosis of macrophage activation syndrome. So with this in mind, we repeated the analysis, excluding LDH from the definition of a complete response. And with that, the number of patients with a complete response increased to 72%. Perhaps the most relevant number from this study, relevant to our clinical practice, was something that was defined as a clinical remission of MAS. And clinical remission was a remission based on the judgment of the managing physician. And the clinical remission by week 8 was achieved in 82% of the patients. So I think it was a very remarkable achievement in this clinical trial. Again, it was a very difficult group of patients refractory to multiple medications, patients with multiple comorbidities. And the remission rate was 82%, which I think for this population is very high. So I think the results of this trial are clearly encouraging. And I think I hope that this treatment will be eventually approved for patients with secondary HLH in general.
It certainly looks very promising in terms of the outcome for this. And I'm also very struck by the techniques used here, in terms of how to do these measurable outcomes. And not only for this study, I think this will set the standard for many future studies for MAS in comparing the efficacy of both this agent and perhaps other agents in the future to really allow us to see the efficacy comparing these agents across the different regions of the world in the future as well. So really,
the other aspect I would like to briefly discuss is the very interesting PK/PD data generated in the trial. So again, we use CXCL9 as a measure of interferon gamma activity. As you probably know, the circulating levels of interferon gamma typically do not reflect the tissue activity of interferon gamma very well, because interferon gamma is retained by the tissues and consumed in the tissues. So really only a very small fraction of it reaches the peripheral circulation. CXCL9, in contrast, is induced by interferon gamma, almost exclusively by interferon gamma. It's stable. It's easily measurable in the peripheral circulation, and now it's emerging as a good clinical test to monitor interferon-driven diseases in general. So in this study, we use CXCL9 again as a measure of interferon gamma activity. So as you can see, the treatment with emapalumab led to a very, very quick neutralization of interferon gamma activity in the tissues. And if you look at the typical biomarkers of MAS activity, including ferritin and soluble IL-2 receptors, they behave very, very similar. So they parallel the behavior of CXCL9. And again, this tells me that there is a relationship between neutralization of interferon gamma and clinical improvement, proving that in fact it is the drug that leads to this improvement rather than sort of a natural evolution of this phenomenon.
And Dr. Grom, can I ask you, is there a difference in CXCL9 versus CL10 in this sense? I mean, the peak looks a little different. CXCL9 comes down pretty quickly, and then on this graph from this.
Yes, CXCL9, that's an interesting point, because CXCL9 is certainly induced by type 1 interferons, and that potentially that could reflect some type 1 interferon activity as well in this patient population, correct?
Yeah, it seems like the improvement of CXCL9 is even faster than ferritin, at least by a small margin, right, as a marker of efficacy. Very well. All right. So I think as we talked a little bit more about type 1 interferon, that's been mentioned in multiple places, right? We talk about, the focus of this conversation mainly started with interferon gamma-driven diseases. We talked a little bit about the overlap of type 1 interferon and type 2 interferon pathway. So type 2 interferon, again, being interferon gamma, type 1 interferon, we think of this interferon alpha, interferon beta, which we focus more in the context of viral infections traditionally, right? These are the typical antiviral cytokines made by most cell types in the body. And one disease that we think more about type 1 interferon rather than interferon gamma is systemic lupus erythematosus. So this is a prototypical autoimmune disease that we treat in rheumatology, where the body makes lots of antibodies against different antigens, particularly nuclear antigens. And patients get very heterogeneous features, including skin inflammation, kidney inflammation, liver inflammation. Really, almost any organ can be involved in lupus. We don't think of HLH so much together with lupus traditionally, because these are seemingly separate entities, both from a management standpoint as well as a physiologic standpoint. But maybe we were wrong before. So I think this is a very interesting poster from Dr. Pui and colleagues, I will pronounce the name correctly, looking at incidence of MAS or secondary HLH in patients with lupus that are hospitalized. I think one of the challenges for us to recognize MAS in patients with lupus is some of the overlapping features, right? We look at MAS with lots of cytopenia, right, low cell count, and we see that in lupus. Maybe because of other reason, right? We have antibodies target lymphocytes and neutrophils to take those cells away. It could be a production issue as well. So it does mask our ability to pick up some of the salient features of MAS. And of course, there's some cytokines that in lupus are well recognized now that type 1 interferon is the hallmark of this condition, right? There's lots of type 1 interferon, interferon alpha, and interferon beta in this disease that seems to drive the autoimmune component of making autoantibodies. A lot of research have gone into looking at whether interferon appears to be upstream, and we see that in other diseases where there's lots of interferon around, type 1 interferon, that's what I mean, that we also see the presence of autoimmunity and development of autoantibodies. So in this study, that they look at patients with lupus in the hospital setting and actually studied their both at a clinical level as well as a biochemical level, looking at features of MAS, secondary HLH. And they found a number of predictive factors, right? So elevated ferritin, cytopenias, liver dysfunction are perhaps the strongest predictors of secondary HLH in patients with lupus. And as mentioned before, some of these are also features that we see in lupus disease itself, so it makes it somewhat difficult to recognize. But they did say that early identification of these patients, it can be really helpful, right? Because it's, as we know, secondary HLH is a very dangerous disease, right? With delay in recognizing this condition, there's a significant increase in mortality and morbidity. And in this study, they found the prevalence of HLH fitting this criteria is 0.13% in 139 patients. Which may not sound like a lot, but I think it is still a condition that's under-recognized due to the overlapping clinical features. And they did find increased risk of HLH in certain groups, including those that are younger, patients that are female, and certain races include African American, Hispanic, Asians, and Native Americans. Interestingly, older age is actually protective against HLH in this study. So I think this is a really important study in highlighting that MAS is just not a condition that is restricted to Still's disease or systemic GIA. It's also a feature found in other systemic autoimmune diseases, including lupus. And that also ties in some of these cytokine connections, right? Type 1 interferon in lupus perhaps is a predisposing factor to generate the profile of T cells that make interferon gamma and really bring home the message of how these two types of interferons can act together in driving a cytokine storm. And if Dr. Grom have other thoughts on this?
Well, the only other point I would like to make, to me, it's interesting that the prevalence of MAS in lupus was higher in Asian Americans. If you think about secondary HLH in general, induced by infection, it's much more prevalent in Asia. I see very interesting parallels between what we see happening in lupus, but also what happens with secondary HLH induced by infection.
Yeah. I think that the type 1 interferon may be a connection between the two also, right? Because type 1 interferon is a key hallmark of most viral infections. And of course, viral infections, especially EBV, right, which is very common in the Asian population, as you mentioned, is a key driver of HLH-MAS, even in healthy people. So I think that's, maybe it's a cytokine connection that brings all of these diseases together in terms of the risk for secondary HLH. So, all right, and then the last study I'd like to highlight here is the Metaphor project, which looks at a global perspective of how we treat MAS across different locations. So this is presented by Dr. Rogani and colleagues. And so their objective of the study is to look at real-world treatment practices, right, using international survey, and to present the majority of data from the Western Europe, Eastern Europe, as well as North America. There are some common things, right? So I think steroids, when we think about the first line of treatment for MAS in the context of systemic GIA, that's fairly consistent across the board. Most places use that as the first line of treatment for systemic GIA. What becomes more variable is the second line, right? What do we do next, or what do we do together with steroids? And Anakinra was one that they showed used in a lot of places as a second line treatment. But of course, in many places, we also use that as a first line, where for systemic GIA to begin with, many patients are treated with systemic GIA, whether they have or don't have MAS at baseline. And this study also goes on to show that as we go into the second and third line, there are more and more heterogeneity in terms of using the different medications that are available, including anakinra, cyclosporin, and etoposide, right? Thinking about more intense chemotherapeutic agents to reduce the pathogenic white blood cell populations. So that's a lot of part of the practice also dependent on availability. Right? IL-1 inhibitor in North America is seemingly fairly available in most institutions, but in Europe and beyond, in other places, and in Asia, for example, they're often not available. And the practice would change towards more perhaps IL-6 inhibitors and cyclosporin and other agents. And this study also extends to MAS associated with lupus. And so it's also showing this figure here, there variable practices across the globe in treating MAS associated with lupus. One of the key messages here is that when we all do different things in different parts of the world, it's really difficult to analyze the efficacy of these individual agents and see what's best for each of these conditions. It's entirely possible, of course, that the treatment for MAS in the context of systemic GIA could be different in terms of efficacy from those of MAS associated with lupus. But if we don't have more of a consensus in terms of these treatment algorithms and everyone's doing different things, it would take a much longer time using a lot more studies to really get to the bottom of what is really most effective for treatment of MAS. These are also more traditional agents, right? This study doesn't include some of the newer practices, emapalumab, Dr. Grom mentioned in the last study, or the JAK inhibitors, which has made its way through rheumatology for treatment of many conditions now, through this ability to block type 1 interferon and also type 2 interferon gamma, among other cytokines. Dr. Grom, do you have other thoughts on this?
We need to talk to each other more and more, and certainly there is a clear need for a kind of more unified approach to this patient population. And I think the group that presented this poster are clearly leading this effort. They are very energetic, and I'm very, very enthusiastic about this study. I think it will be very meaningful. Yes, briefly, let's talk about the key takeaways from the ACR 2024 meeting. I think the first point is interferon gamma now is clearly emerging as a pivotal cytokine driving inflammation in conditions like macrophage activation syndrome and HLH. But we're also learning that we need to be paying attention to other cytokines, including IL-18 and perhaps type 1 interferons, particularly in lupus. We're also learning about distinct clinical patterns in liver involvement in systemic juvenile idiopathic arthritis. Clearly, there are patients with chronic recurrent macrophage activation syndrome confined predominantly to the liver. It's a very challenging patient population, and there are Clearly, the histopathology of this clinical phenomenon is different. Hopefully, soon we will have additional biomarkers, blood biomarkers that would help us diagnose this clinical phenomenon early. We are learning that the immune synapse duration correlates with the production of interferon gamma. We are learning that it could be a good clinical test that would help us assess the significance of variants of uncertain significance in the genes in the cytolytic pathways. I could clearly see the role of this assay in clinical practice. We're also learning that MAS is quite prevalent in patients with lupus. The diagnosis of MAS in lupus is difficult because of the many overlapping features, including cytopenias. And it looks like elevated ferritin as well as liver enzyme elevation could be a good predictor of a risk for MAS in this patient population. On the clinical side, emapalumab is emerging as a very effective treatment strategy for patients with refractory MAS presenting as a complication of Still's disease. It still remains to be determined whether the same approach could be effective in patients with MAS in lupus. In conclusion, the better we understand interferon gamma-driven pathways in various diseases, the more biomarkers we have to measure activation of those pathways, the better we will be in terms of management of these conditions. And again, the future directions will include the further examination of the role of additional cytokines like IL-18 and type 1 interferons and their role as potential targets for therapeutic intervention. And certainly this will require some global collaborations. Thank you.
Yeah, so thank you, Dr. Grom, for this wonderful summary of some of the really insightful studies that we've seen at ACR this year. And I really look forward to reading some of these studies in print in their manuscript that hopefully we publish in the coming year. So with that, I'd like to thank all of you for joining us for this segment. Be sure to click on the landing page of this activity to claim your CME credit and to access supplemental slides and other topic segments that will be discussed. So thank you.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.